Oh, you know that. It's thank you. Forward. Oh, great, outstanding. So, thanks everyone. I've really been looking forward to speaking here today, and I'm going to do everything I can to keep this as interesting as possible. Talk to you about some of the challenges and some of the things that are absolutely unique about wireless health product development, unlike anything else. All right. So I'm part of the Wireless Health Institute with Dr. Bruce Dobkin and Majid Sarafzadeh. And you'll learn a little bit more as we proceed. Okay, so I want to give you just a little bit of a look ahead about product development. Everything I'll be talking about here involves products on the market where the initial concept is driven by a missionary in UCLA healthcare. I simply can't say enough about how important that is. We'll talk about the SEM scanner, which is the first evidence-based method for detection of pressure ulcers, and ABSTATS, the first wearable monitor of human digestion. And then there's several other firsts, and I would like to talk about at the end about the Depression Grand Challenge, which is an amazing opportunity. So we're dedicated to end-to-end product development in all these different areas. All right. I can't emphasize this I can't overemphasize this. You know, we're inundated with news about new products constantly, whether it's the Pokemon Go system or a wearable device, a smartwatch. And I want you to just really think about this. With conventional information technology, whether it's anything from an app to a device, the development can occur almost anywhere. It can be outside of a formal development. I always like to think that the next social media breakthrough, something that workplace Facebook, for example, right, is probably being developed in a garage somewhere. It might be overseas. It might be in Orange County. It might be 3 miles from here, right? But wireless health is fundamentally different. It requires that the innovation center be embedded with a healthcare provider. Okay. You can't develop an mHealth device that affects care, I believe, outside that environment, at least not very rapidly. And I think you'll see why here. All right, so here's the process. It's fascinating. And again, it's very different from what occurs in conventional information technology. First of all, I have to just attest as an engineer, you know, and an individual with a science background, that like lots of engineers and scientists you run into, you're often inundated by their ideas for how they might solve the healthcare problem. And you're probably used to telling people, well, it's a lot more complicated, right? I think you've all had that experience. The concept we find almost always has to initiate by the clinician expert. And then the science might be co-developed, where physics and physiology lead to foundation methods. And then, really critical, designing a transducer. What do we measure? Okay, now, efficacy is clearly important, safety, and then if you don't incorporate regulatory constraints at this stage, it's going to fail. Or you're going to have to completely redo every step in the process. And this means CE mark and FDA. Okay, then analytics, whether this is part of the device or remote, addresses accuracy, specificity, but also has to involve regulatory considerations. And the bad news about this is none of this is ever written down. There's no book written. There's no one you can talk to. In fact, in many of the regulatory guidance is kept secret for good reason. So the only way to be successful at this is to have been successful before. It sounds kind of like an impossible problem, and it almost is. Okay, you have to learn from someone else, and I've been fortunate to be able to do that. Now, here's another thing that makes, sorry about this, I pushed the wrong button here, a usability problem. So critical that the product development involve early trials. That is, how does one develop analytics or define a transducer without actual experience with human subjects? And so in conventional information technology development, like building a faster wireless interface for cellular telephony, that can be done in a laboratory and traveling in the environment. But and that testing is essential for that product. Here, the testing and the refinement has to involve subject trials. And this is very difficult to do outside of the healthcare provider environment. It may be one of the reasons why many organizations are turning from an internal development mode to a more acquisitive role, like say Johnson & Johnson and the development of devices, because it's very difficult to develop internally because of this constraint of not owning a hospital. Okay, now what happens next? Well, there's a design and then intellectual property. And this is again something where there's a lot of theory and valuable things to learn, but it's one of those things that requires experience. And then there's product development, defining it, developing a license, and at this point, a partnership. You might be aware that you need a great deal of resources to bring a product to market. And unfortunately, the federal government can't be asked to fund it, either because the agency is structurally unable to, which is generally the case, or lacks the funds. There's production, planning, and again, regulatory. And now another set of trials that validates and again has to comply with regulatory requirements. And then it's still moving along. We're not at the end by any means yet. There's certification. We have to go to an independent outside body that verifies that the design will be safe. FDA requires the CE mark organization to review the product. Then FDA. Okay, so we've been through this in multiple phases and multiple products, and I'm involved in one right now, and it's going to require over 100 documents. I have to write over 100 documents to make this happen. And can you delegate it? Not really. Okay, it's like writing multiple PhD theses at once. So then there's pre-submission. This step might be skipped, but generally not, where we pre-submit to FDA and obtain refinement from FDA, and then there's submission. And then at this point, there's a delay while we're waiting for FDA approval. And during that time, there's partner support and trials. And by the way, by partner, we mean a company that has licensed the technology that wants to take it to market. And companies recognize this enormous value associated with organizations that are dedicated to delivery of a product. Contract manufacturing support, partner support, and finally delivery. And maybe let me go back to one more thing here. This concept led by a clinician expert. So these clinician experts are individuals that have for their life been battling with a healthcare unmet need. And their objective is not another paper or another grant, but a product on the global market that will solve the problem. That's what they want to be remembered for, and that's what we want to be able to support. Okay, so here's an example, maybe a good quintessential example of the first evidence-based method for detecting pressure ulcers. Okay, so pressure ulcers lead to twice as many deaths annually as all car accidents. They're terrifically expensive, lead to lawsuits, and the prevalence of pressure ulcers is huge, 24% among patients in nursing homes. The pressure ulcer, you may know, results from the application of pressure to tissue. If we lean with our elbow on our desk like this, after a short period of time, we develop a pain. Well, not someone suffering from diabetes, for example, might not develop such a pain, can't detect it, and after a period of time, an ulcer occurs. In the case of diabetes, the foot ulcer occurs very often due to neuropathy in the foot. Every 20 seconds, someone loses their foot due to this by amputation. And sometimes the amputation doesn't heal for the same complex of reasons. Someone of you may know of the actor Edward James Olmos, famous actor. He has a foundation in the Valley focused on reducing the incidence of amputation due to diabetic foot ulcer. He has, I think it's 5 uncles or five adult male relatives who have all died as a result of pressure ulcers. All except one who committed suicide when he discovered he had a foot ulcer. One of the things that's very difficult here is that detecting an ulcer requires visual inspection. Very few people are trained to do this. And it's virtually impossible in darkly pigmented skin. Working with a hospital, I won't name them, I was investigating usability for this particular product. It's on the market now at an early stage trial. And I wanted to interview people and discuss usability, and I was advised to talk to the skin team. That's the team that goes through the hospital to determine whether or not patients are turned adequately and so on. And I said, well, when can I meet with them? And the individual who introduced me said, well, I'm sorry, but I've been here 20 years and I've actually never seen the skin team. So this is an unaddressed problem. I've actually never seen a patient turned. Now they are. If you talk to a nurse from like the 1960s, they're aghast at that. I can't blame anyone. We have our patients instrumented with tubes and electrodes, and they need to be on their back. Okay, well, anyway, that's another long story. Well, Dr. Barbara Bates Jensen here at UCLA, in both nursing and our School of Medicine, has devoted her life to understanding the origin and treatment of pressure ulcers. And she developed the concept of characterizing pressure ulcers by examining the moisture that exists under that aggregates under the epidermis as a result of a deep pressure ulcer wound. That led to our developing a device that characterizes this subepidermal moisture, hence SEM, subepidermal moisture. And then we went through everything I talked about here, and I won't go through all the details. But massive set of trials. And it's on the market right now. This hospital performed their own independent assessment and has, and you'll be able to find this information online, has an enormous reduction in pressure ulcer occurrence in their hospital. It's been adopted by providers, Virgin Care and Health Canada and others. It received an award in 2015, and there's a Wall Street Journal interview video on Health 360 that you can find, just came out a couple days ago. All right, here's another example, same process. In this case, it was Dr. Brennan Spiegel here in medicine, public health, and also with the VA, who called me up one night, and it was one of these, I've had a few life-changing phone calls in my career, and this was a life-changing one, where like in the first sentence, you know that your life is going to change. And he said, you know, I'm familiar with, or I've learned about wireless health and remote monitoring. Is there something that we can do to monitor human digestion? And well, as it turns out, I had a background in the characterization of organ function via detection of vibrational waves, and I knew right at that instant we'd be able to proceed. Well, okay, digestive disease, urgent unmet need, and I'll skip over these details, so I know you're familiar, but it accounts for nearly 10% of all deaths. Inflammatory bowel diseases, for example, affect the entire worldwide population. Readmission for colorectal surgery, for example, is the highest of all procedures. Okay, well, the gastrointestinal engine is what we want to characterize, and it's terrifically fascinating. There's an enormous amount of brain tissue that is needed to manage this terrifically complex system. Imagine a system that allows you to eat carrots or carrot cake, convert that energy with about a 25% efficiency actually into glycogen delivered to muscles. It's difficult to do that with a car using reagent-grade gasoline. Okay, so ingestion, the stomach is responsible for food blending, protein extraction, and then sequencing of food boluses. With knowledge of the composition of the food so as not to overload the intestine. And then we now have the duodenum, which detects the arrival of a food bolus, meters out the appropriate amount of gastric acid. I mean, imagine this is a complex chemical engineering factory. We absorb iron, and then the small intestine absorbs fat and carbohydrate. And then we've evolved to try to extract the water from the food bolus that has already been processed. And so we store food for up to 72 hours in a large intestine while we're extracting water from this. Long story, but fascinating. Okay, many gastrointestinal disorders, ranging from the effects of cancer to gastroparesis resulting from the fact that diabetes creates a neuropathy in the stomach that prevents the stomach from detecting that it is full. Complications in the duodenum, small intestine, and large intestine. What do we have available? Well, the methods for characterizing include things like this pill that can be swallowed. Physicians don't like it because they have to watch 72 hours of video, and the activity that one wishes to detect may or may not even occur when the pill is at this point. And the manufacturer of this pill notes that 1 in 30 of their patients has the pill stuck, and it needs to be removed then surgically. There is this device that is inserted through the nasal passage, esophagus, into the stomach, and under continuous X-ray, and a wizard surgeon is routed through the sphincter valve in the stomach to just the first few inches of the duodenum. And then there's this, the stethoscope that can be used to listen to abdominal sounds. It's, even though it might be used in practice at some time, and it was, I've never once ever seen it used on an adult subject, but it is used for infants. Okay, well, nature is kind here in this particular sense. It turns out that all these events that involve digestion of food require a great deal of energy. About 10% of all the energy that we eat is directed towards the processing of food, thermogenesis. And none of this processing can occur without a great deal of vibrational wave of sound. Imagine that you've had a bowl of carrots for lunch, and imagine that your objective now is to crush that bowl of carrots with your hands into a fine liquid to enable further processing. First of all, it's going to be exhausting, and there'll be a great deal of energy emitted when that occurs. So that means we can detect chewing. It's possible with the sensor here between the clavicle and the first rib to actually detect swallowing and even classify the type of food. Okay, fascinating. The stomach exhibits contractions, the duodenum peristalsis events, and so on. So it turns out there's a wide variety of different, now, and I'll show you the geologic product in a moment, but there's belt systems, there's adhesively attached systems, and wireless systems for a variety of different applications now for what's called abstats. What we discovered with every single subject we've ever characterized, hundreds now, is that everyone exhibits this waveform. This is a peristalsis event. It's a muscular contraction that's required to blend food and move food. If you think about this, we have 30 feet of intestine because we have to be able to move the food bolus from point to point and present new nutrition material at the intestinal wall to enable an exchange. After that exchange occurs, obviously that cell tissue has now been recruited and it's no longer able to extract further nutrition. So we have to move the bolus forward. Can you imagine the complexity of sequencing this? Well, if we look at with an external sensor on our abdomen, all of us would show this right now. First of all, you would hear the sound of circulation, but you might recognize first sound and second sound in each beat here. And then occasionally, these sudden events. And if we stretch this out in time, it appears this way. And again, we all have this right now. And so developing a classifier for this unique waveform is possible. It's also, here's a case of nature's kind. This waveform is difficult to generate by any means. So external noise really can't create this. It doesn't mean that external noise will make is completely absent and something that can be ignored in classification, but the uniqueness of this waveform certainly is a big advantage. So the first objective that Dr. Brennan Spiegel pursued, and that GI Logic, the company that's licensed this technology, is pursuing, is that of postoperative ileus. During abdominal surgery and many other surgeries, including orthopedic surgery, immediately after surgery, the digestive system is effectively paralyzed, either by trauma and pharmaceuticals or one or the other independently. Now, postoperative ileus means that if we ingest food, the food will not be processed. So you can imagine what happens if you eat a meal and this arrives in your 98-degree Fahrenheit internal furnace. It's not long before that will spoil and lead to a variety of great risks, including intestinal burst. How do we determine if someone is suffering from postoperative ileus? Well, today the subject is asked, how do you feel? Okay. There's the manual stethoscope monitoring, but this is very difficult. It requires a physician to be in attendance and listen for many, many minutes. And as it turns out, these events are not audible. We hear them due to a series of accidents. And I don't think anyone really is capable of separating this from other confounding events that I can tell you about later. So there's, as Brennan Spiegel puts it, a delicate balance. On the one hand, if we feed too soon, there's great risk. If we feed too late, then there's delayed nutrition. And this is quite serious. We can't fast forever and live on, for example, an intravenous feeding, because the digestive tract, as you might imagine, the 30 feet of intestine, gets a great deal of its nutrition from the food itself. There's just not enough vascular blood delivery for 30 feet of intestine to enable it to stay alive on its own. Okay, so it's an expensive problem, and I'll skip over this and move on a little bit. We went through the early trials, so we're very fortunate to have worked with the Veterans Administration, and I attended around 90% of these, and demonstrated early on that we could separate post-surgery ileus subjects from those that were healthy or those that could return to health. And that required, obviously, expert clinician classification and observation of the history of the subject, and then our data. So that led to Brennan Spiegel's concept here for adding Abstats as a monitor, and at Cedars-Sinai, he's developed a fascinating set of results. Well, the device returns this motility metric, which is effectively a count of these peristalsis events. And Dr. Spiegel studied this a great deal, and it's been really amazing. Here's the subject with a value just before postoperative, just before surgery, and then at the end of day 1 of surgery, there is a characteristic increase in motility, and then a general increase, and this person returned to health. Now, there's a controversy. Right now, virtually everyone that treats patients for conditions of the type here for this patient and abdominal surgery wishes to speed a positive outcome, of course. And so the term is aggressive feeding, feeding someone early. Here's another case of a person exhibiting full recovery. Here's another case. This subject showed initial characterization and then low peristalsis. Now, this is observational. So the data from this particular device can't be used to guide care, but it can just be provide background. They were aggressively fed, and at this point returned for surgery due to a complication resulting from this. So Dr. Spiegel performed a trial here, 28 subjects, 9 with postoperative ileus at Cedars, but with the objective of being able to predict future ileus. He showed that applying statistics on the motility characteristics for postoperative day 1 and postoperative day 2 would lead to a predictor. It has over 80% ROC area, and is now leading to a whole set of new important opportunities. Going forward, there's an opportunity now to actually optimize nutrition for patients. Here's an interesting article, physician-delivered malnutrition. Why do patients receive nothing by mouth or a clear liquid diet in a university hospital setting? Really fascinating article. Okay, I need to move on, but I'll just tell you a little bit more. We now have a new metric that monitors nutrition transport, characterizes the food that is in the GI tract, and characterizes the time and energy cost of food processing. It enables optimization of the delivery of nutrition. You know, imagine that. We all eat, but none of us really has a chance to optimize nutrition. And which is fascinating. Why does a marathoner eat breakfast 4 hours before the event and never more than 500 calories? Well, it's because the residency time in our stomach, where we recruit no carbohydrates really, and not at the rate of the small intestine, is 2 hours. And then residency in the small intestine is 3 to 5 hours. So that means that you're going to get the full recruitment of food that you eat. I need to almost done here. In after hours. Is that true for everyone? No. Everyone has a different set of characteristics. Imagine being able to adjust that to control weight, wellness, well-being, sleep quality, athletic performance. And then I'll just end here as I think I'm at the end. The biggest opportunity we see going forward right now in all of this is mental health and wellness. Depression is the #1 disease on earth. 800,000 people committed suicide, most due to depression. The loss of life here is greater than for all current wars combined. It has a huge toll on our workforce. The UCLA Depression Grand Challenge, which is led by Dr. Nelson Primer, involves over 100 faculty, 20 departments. Eliza Congdon, who is here, is an engine behind the UCLA Depression Grand Challenge. We meet many, many times per week, and it's terrifically exciting. And the multi-decade goal is a 100K subject trial that will combine everything from genomics to behavior to understand the triggers of depression and ultimately its treatment. So continuous monitoring has proven fundamental benefits. We have lots of examples of that right now. And the next phase will be guidance, where we acquire this information and develop optimized guidance through machine learning that's adapted to each one of us for any outcome. including general human performance. And overall, it seems really clear that something lying ahead is the acquisition of all this information and sharing it in a searchable way for everyone. It will be by far the largest and most valuable information resource. So very exciting next few years. Thanks very much for your time.